Okay, good morning. Today we'll discuss musculoskeletal, and since the PowerPoint has over 70 slides, we will divide the presentation in two videos. Okay, let's start about range of motion terms. Flexion and extension. I provided pictures of all the functions, but flexion is no more than motion away from the zero position. And most joints have this type of movement and range of motion. Extension is return motion back to the midline or to the same position. And again, the majority of the joints have this range of motion. Adduction is no more than movement towards the midline. Examples of these range of motion joints are shoulder, hip, metacarpophalangeal, metatarsophalangeal joints. Abduction with the B in the middle is movement away from the midline. And again, the same joints are examples of this movement: shoulder, hip, metacarpophalangeal, metatarsophalangeal. Inversion and eversion. Inversion is turning of the plantar surface of the foot inward. Examples of these joints, of course, has to be the subtalar and mid-tarsal joint of the foot. So it has to be the foot, because inversion is no more than turning of the plantar surface of the foot inward. And eversion is the same but outwards. So the same joints of the foot are involved. Internal and external rotation. Internal rotation is turning of the anterior surface of the limb inward. An example of these joints are shoulder and hip. External rotation is turning of the anterior surface of the limb outward. And the same joints are examples of those, shoulders and hip. The last range of motion term is pronation and supination. And pronation is rotation so that the palmar surface of the hand is directed downward. Examples of this movement is elbow and wrist. And supination is rotation so that the palmar surface of the hand is directed upward. And examples of this are the same, elbow and wrist. These are pictures of all the range of motions. You have here extension. You have extension and flexion backwards, and you have dorsiflexion of the foot and extension of the foot. You have abduction, which is separation from midline, and adduction is moving back towards midline. Inversion and eversion, remember, is the movement of the foot inward or outward. So this is the neutral position. You have inversion and eversion. You have external rotation, and internal rotation is basically the movement towards the midline and outside of the midline. And pronation and supination, in this case, will be the wrist. Other terms, remember that articular structure or joint, capsule, and examples: auricular cartilage, the synovium and synovial fluid, and intra-articular ligaments. Non-articular structures, examples are tendon, bursa, other ligaments, muscle, fascia, etc. You need to know this. This is very important. Types of joints. Synovial joint is a free movable joint. You had this concept before in pathophysiology. Examples of synovial joint is the knee. Cartilage, the rib is an example, and has a slightly movement, so the limitation is compromised, but it has slightly movement with inspiration. Fibrous type of joint is immovable, so there's no movement at all. And examples of those are the skull. Other type of joints, you have ball and socket, which is no more than the articular shape is convex and has the cavity concave. The movements that you could do with a ball and socket is wide range, flexion, extension, abduction, adduction, rotation internally and externally, and also circumduction. In other words, going in circles. And examples of those, remember, is your hip. That's the most common example. You have the hinge type of movement. Is basically flat, slightly curved, and the motion is only in one plane. You only have flexion and extension. You also have the condylar, which is convex or concave, and the movement is of articular surface. This is a refreshment of the type of movements that you had already in pathophysiology. Again, different type of movements, and examples of those. You have synorthosis, which is an immovable joint, and those are sutures of the skull. You have amphiarthrosis, which is slightly movable, and here remember you have the ribs, you have the vertebra, and the diarthrosis is freely movable. You have the shoulder is the best example. Let's talk about different deformities. You have, for pediatric population, the genus varus and the genus valgus. The genus valgum, or commonly called knock knee, is a condition in which the knees angles touch in one another. Individuals with severe valgus deformities are typically unable to touch their feet together. Causes of that is basically congenital. Rarely, the bone marrow formation underlying knock knees can be traced to a lack of nutrition, but conditions such as rickets could provoke this disease as well. How do you diagnose this? Basically by x-rays. And the treatment for this is mostly surgery and nutritional imbalance correction. Genu varus is no more than the bone angulated away from the midline. It's also called bow leg. And normally children until the age of 3 or 4 have a degree of Genu Varum. The child sits with the soles of the feet facing one another. And after this time of life, the changes start occurring, and the kids should have a normal access or direction of the food. So after the age of 4 is when you have to start worrying about these deformities. Causes, again, even though it's a genetic condition, it could be due to malnutrition problems such as rickets, in this case also due to tumors, physical trauma, or infection. And the treatment is no more than surgery. You can use several orthopedic devices to try to correct the deformity, but the majority end up with surgical procedure. This is a picture of Genu Varum. Even though here says normal until 18 months of age, you could see many other kids with up to 4 years old. Genus valgum, again, could be normal at the age of 3 to 4, but after that is completely pathological. Common symptoms associated with musculoskeletal system include pain, weakness, deformity, movement limitations, stiffness, and joint clicking. Talking about pain, before we go and discuss this differential diagnosis of monoarticular and polyarticular etiologies of pain, let's discuss about how will you approach a patient with musculoskeletal pain. Pain can result from disorders of the bone, muscle, or joint, and the examiner or the interviewer should ask the following questions. For example, when did you first become aware of the pain? Where do you feel the pain? Can you point to me where the pain is felt with one finger? Did the pain occur suddenly or is it daily? Did any illness precede the pain? What makes the pain worse, and also what makes the pain better? Is this pain released by rest? Because remember, that's one of the differences between osteoarthritis and rheumatoid arthritis. Is it better when you fall asleep? Is it alleviated by any anti-inflammatory? Or, for example, have you had any recent sore throat? And we're going to discuss the most common etiologies for pain. So when you approach the patient with articular pain, you have to ask yourself, is this in one joint or several joints at the same time? Is it unilateral, bilateral? Is it symmetric? Is it associated with systemic manifestations? Okay, let's talk about monoarticular, or in other words, when the pain is only in one side. When it's only unilateral, you have to think, for example, about gout. And remember, gout is no more than accumulation of uric acid in the joint. Okay, and basically, pathophysiological wise, when you have to think about unilateral, is either is it inflammation, and when it's inflammation, is it due by crystal-induced arthritis such as gout? Is it due by infection, or is it any trauma associated with it? Okay, so when you think about gout, remember that this is most commonly associated with the metatarsophalangeal joint in the ankle or knee, but remember the great toe is the most common presentation. It's acute, it's self-limited. Remember, sometimes you have visible tophi. And how do you diagnose this? Basically by the visualization of crystals in arthrocentesis. What about hemarthrosis? And this hemarthrosis is basically patients that have bleeding disorders. Okay, so these patients, most of the time, they have a spontaneous bleed. For example, if they have factor 8 or factor 9 deficiencies, such as hemophilia, they get hemarthrosis. And these patients will complain of acute pain and effusion that is spontaneously most of the time, and most of the time is in the knees, and could be associated with trauma, but if it's a bleeding disorder, could occur spontaneously. How do you diagnose this? Again, by arthrocentesis. Let's talk about infectious process. So whenever you have an infectious arthritis, it's always unilateral. Rarely is symmetric because it's not a systemic disease. So patients with infectious disease, they have an acute onset of pain, swelling, and warm. So the actual joint is warm. They have decreased range of motion. It's very common present in immunosuppressed patients, patients with IV drug users, diabetic patients, any patients that has been prior on antibiotic use and now is immunosuppressed, patients with HIV, etc. And again, you diagnose this by arthrocentesis. Lyme disease is another infectious process, and if you remember, this is caused by Borrelia burgdorferi and is monoarticular, patients would have the prior manifestations of Lyme disease and the prior history of being camping and being bitten by a tick. They have erythema migrans, fever, malaise, etc. And how do you diagnose this? By serological studies, having antibodies against Borrelia. Osteoarthritis. This is very important to remember. Remember that it's a chronic, indolent pain, and if the pain occurs is mild type of pain, is usually in adult, elderly. Remember that these patients have bony deformities, hypertrophies. They have a history of joint overuse, for example, in athletes or patients that are in construction, putting floors, or farmers, etc. Remember the deformities of osteoarthritis. Osteomyelitis is another type of infectious process. Remember that even though patients would have systemic manifestations, it's basically unilateral. They have fever, joint swelling, erythema, and the best diagnostic test is basically a bone scan, but you could do it by CT or MRI. Other periarticular diseases such as bursitis, epicondylitis, fasciitis, tendinitis, all those itis, remember, is unilateral, is monoarticular. Patients will have pain with active joint movement. So if you tell the patient, okay, can you raise your shoulder, you're going to have pain associated with that movement. And that's basically like supraspinatus or infraspinatus bursitis. Also with passive range of motion, the point tenderness and sometimes swelling is associated with the disease. And how do you diagnose this? Basically by clinical evaluation, and also you could do gram stain culture in the synovial fluid. Trauma is another cause of unilateral type of pain, and is also associated with joint movement, but you have the history of recent trauma. How do you diagnose this? By X-ray, and sometimes MRI is needed. Tumor, you also have to think about malignant diseases when the patients have pain in joints. It's insidious, it's slowly progressive, they have a constant pain, and you could do this by X-ray or MRI. Now let's talk about polyarticular. And when you say polyarticular, you mostly think about systemic diseases such as rheumatoid arthritis, scleroderma, lupus, Sjogren disease, etc. Well, let's talk about acute rheumatic fever. Remember, this is a severe migratory pain affecting legs, elbows, wrists, etc. They have tenderness more severe than swelling. They have extra-articular manifestations, and this is the main point of polyarticular diseases. They have fever, they have cardiac dysfunction, they could have valvulopathy, murmurs, they could have serositis, and serositis-wise, they could have carditis, effusions, pleural effusions, pleuritis, etc., subcutaneous nodules. And remember that in acute rheumatic fever, they have a history, a prior history of post-streptococcal pharyngitis. This is very important to remember. Diagnostic approach, well, basically you test for streptococcal infection with a rapid strep test or cultures, or you could do also antibody titers, such as anti-streptolysin O. EKG and echocardiogram or chest x-ray, you basically do it to diagnose serositis. Let's talk about, even though not common in practice, but you could see a few cases, hemoglobinopathy such as sickle cell disease, they produce a lot of pain in the joints. So basically, patients have a severe type of pain when they have a cycling crisis. Remember that this is African Americans or patients that are Mediterranean descendant. And every time they have a crisis, they have a severe joint pain, and it's systemic, it's polyarticular, it's bilateral, symmetric. And how do you diagnose this? By hemoglobin electrophoresis. Other rheumatic diseases, not included rheumatoid arthritis, is Sjögren's syndrome, dermatomyositis, polymyositis, systemic sclerosis, lupus. And besides the fact that patients would have polyarthritis pain, patients have manifestations related to the underlying disease process. For example, if the patients have systemic sclerosis, they have dysphagia. If they have dermatomyositis, they have dermatological symptoms associated with it. If they have Sjögren's disease, they have Zika, which is dry eyes, dry mouth, dry skin, dry everything. Lupus, remember the discoid lupus manifestations, and they would have pain associated with it. So basically, how do you diagnose this? Is by finding the antibody against the actual specific disease process. For example, for Sjögren's syndrome, you would find antibodies anti-SSA and anti-SSB. You don't need to know all this in details. It's going to be in your specialty areas discussed in detail, but it's just to have a better idea. If you're thinking about lupus, you basically look for your antibodies anti-dsDNA. If a patient has psoriasis, they also could have psoriatic arthritis. And basically you will see the plaque patches in the most common locations, basically in the extensor areas. And you also could have serositis, uveitis, tendonitis, etc. Rheumatoid arthritis, remember, is very common to be present in exams to compare with osteoarthritis. And remember, rheumatoid arthritis is symmetric. Most of the time occupy the proximal interphalangeal joints. Small and large joints also are involved. They also are associated with serositis, the same as the other rheumatoid diseases. It's most common among young adults, but it could manifest at any age. And the clinical evaluation is most of the time looking for the antibodies and x-rays as well. Now let's talk about low back pain causes. You could have a midline pain, which is no more than muscle strain or herniation of the nucleus pulposus, or if you have a spinal cord metastasis. Pains of the midline is most of the time associated with sacroiliitis, sciatica, and also arthritis of the hip. Let's talk a little bit about sciatica. Sciatica is the pain along the sciatic nerve. It usually results from compression of nerve roots in the lower back. Common causes include intervertebral disc herniation, osteophytes of osteoarthritis, narrowing of the spinal canal, and the symptoms associated are pain radiating to the buttocks, down the leg posteriorly, or it could be anteriorly as well. The etiology is basically a nerve root compression, usually due to intervertebral disc herniation, but also could be due to osteoarthritis or movement of the vertebral bodies, which is called spondylolisthesis. Spinal stenosis, a tumor, could also do it. And remember, the most common symptoms are pain radiating along the course of the sciatic nerve, most often down the buttock and posterior aspect of the leg to below the knee. It could also radiate to the perineum, the scrotum, the labia, A pain is typically burning, lancinating, or stabbing. It may occur with or without low back pain. And the Valsalva maneuver or coffee may worsen this pain due to disc herniation. Patients may complain of numbness as well, and sometimes weakness of the affected leg. The diagnosis is basically by clinical evaluation or sometimes MRI. And the treatment is bed rest, analgesics to try to relieve this pain, which is neuropathic in nature. You could also relieve muscle spasm by giving the patient gabapentin or NSAIDs or benzodiazepines. Surgery is indicated only for a major disc herniation that could produce progressive neurological deficit. Predictors of poor surgical outcome include psychiatric symptoms. So patients with psychiatric disorders should not receive surgery. Persistent symptoms more than 6 months also is poor prognosis. How do you diagnose this disease? Is basically by the straight leg raise. And you do this by basically elevating the leg without bending the knee. And normally the patient should feel pressure in the low back but not pain. You could also do the cross straight leg raise, which is basically that you elevate the unaffected leg the same way as the straight leg test, and the patient would feel the pain at the level of the affected leg. If no red flags, may monitor for 4 to 6 weeks before imaging. And diagnostic imaging does have a high rate of abnormal findings in persons with no symptoms. This is a picture of a straight leg test. And you have another one in your PowerPoint. Now, diagnostic of concern or red flag is, for example, cauda equina syndrome. And cauda equina syndrome is a serious neurological condition in which damage to the cauda equina, which is the end portion of the lumbar spine, where the plexus are connected to the conus medullary. Basically, is no more than a lesion of the lower motor neuron. Patients will complain of severe back pain, saddle anesthesia, which is basically numbness in the level of the perineum, numbness in the genitalia, anus. They have bladder or bowel dysfunction. They could also come in with sciatica type of pain. They could come with weakness of the lower legs, sexual dysfunction. So it's very important that you ask the patient if they have numbness at the level of the perineum, at the level of the genitalia. Have you have any type of bladder incontinency or bowel incontinency? You could also do bladder scanning to see if the patient have a high residual volume. Ask the patient about sexual dysfunction. Causes besides spinal stenosis associated with herniated disc could be tumors, could be trauma, could be inflammatory diseases such as spondylitis, Paget disease, etc. But think about disc herniation is very common associated with that. And the management of a true cauda equina basically is surgical decompression. And of course, you have to rehabilitate the patient for bowel and bladder control and for training exercises to recover muscle tone and strength. Other concerns or fractures, so you have to rule out fracture, you have to rule out metastases, and you have to rule out infection. Management of the most common type of low back pain is NSAIDs. Remember that your osteoarthritis is a mild pain, so you use Tylenol and NSAIDs. And for the severe type of pain, you could use the actual disease-modifying rheumatoid meds for rheumatoid arthritis, for example. You could use opioids, you could use muscle relaxant, corticosteroids, bed rest, exercises, acupuncture, heat or ice, and manipulation. In summary, remember that you have monoarticular and polyarticulars. Monoarticulars, you have to think about, have you had any trauma, any type of infectious or inflammatory process? Polyarticular, remember, think about systemic diseases such as rheumatoid arthritis, rheumatoid fever, or lupus, scleroderma, etc. Let's talk about other symptoms, manifestation. Weakness. Weakness is basically a very common disease or associated symptom of the musculoskeletal, but also is associated with neurological manifestation. Remember, if you have nerve conduction being compressed due to a herniated disc, it could produce also weakness. So it's a loss of muscle strength, although many patients also use the term when they feel generally fatigue or have functional limitations due to pain or limited range of motion. May affect a few or many muscles and develop sudden or gradually. Other symptoms associated with weakness could be numbness or fatigue. And how do you ask the patient if you have any weakness? For example, do you have difficulty combing your hair? If you think about shoulder joint, do you have difficulty lifting objects? Have you noticed any problem with holding a pen or pencil? Do you have any trouble standing up after sitting in a chair? Have you noticed any decrease in your muscle size? Do you have any trouble swallowing, chewing? Do you have any difficulty turning doorknobs? Those are very common questions associated with that. Deformity may be the result of a congenital malformation or an acquired condition. In a patient with deformity, it's important to determine the following. Questions related to it. Is this occur suddenly or is it gradual? Did the deformity occur as a result of a trauma? Those are examples. Movement limitations. Ask the patient. Determine the type of motion that they could do. What type of motions can you do? Can you show me? And these are most of the time in relation to scarring of a joint capsule or the called frozen joint, most likely due to muscle contraction. Joint clicking is commonly associated with a specific movement in the presence of dislocation of the humerus, displacement of the bicep tendon, degenerative joint diseases, damage to the knee, meniscus, or also temporomandibular joint problems. How do you know if it's inflammatory or non-inflammatory? So basically touch the joint. If you have any tenderness, warmth, or erythema, it's most of the time inflammatory. Is it articular? Is it associated with active or passive range of movement? Do I have pain or edema associated with it? Do you have locking? Non-articular. You have loss of active, not passive range of motion, and you have pain outside of the joint as well. Let's do a physical examination. And how do we start this? So basically, by inspection. What are you able to see during the inspection? Basically, look at symmetry. Do you see any nodules, any type of deformity? Do you see any sign of inflammation such as swelling? Do you see redness? Palpation-wise, it could delimit if the patient has crepitus, if it's crunching sensation, if the patient has redness, if it's tender to passive range of motion. Muscle strength and muscle tone also could be delineated in palpation. Let's talk about temporomandibular joint. And when you're doing temporomandibular joint, basically patients with temporomandibular joint problems may complain of unilateral or bilateral joint jaw pain. The pain is worse in the morning and after chewing or eating. So look for those facts. Most of the time, patients complain of this. Every time I chew or eat, I develop clicking or I have pain. To be able to examine the joint for temporomandibular, the examiner places his or her index fingers in the front of the tragus. So look for the anatomy first, where the temporomandibular joint is located. Is pre-auricular. So you're going to place your fingers at the level of the pre-auricular or at the level of the tragus. The examiner observes if by telling the patient open and close your mouth or your jaw, if this range of motion is smooth. So basically, you tell the person to sit down and inspect the area just anterior to the ear. Place the tip of your fingers in front of the ears and ask the person, can you please open and close your mouth? Drop your fingers into the depressed area over the joint and note the smooth motion of the mandible. An audible or palpable snap or click occurs in healthy people. Swelling or any bulging of the joint while moving, any crepitus or any pain is a sign of dysfunction. You could also tell the patient to move the mouth side to side. A lateral motion may be lost earlier when the patient have, for example, osteoarthritis of the temporomandibular joint. Let's talk about gait and spine problems, and we'll concentrate. We already discussed sciatica, so let's concentrate about the actual exam of the spine. Okay, this is the scoliometer. You could basically tell the patient to bend forward, and you analyze the symmetry of the spine. And for a more specific diagnostic evaluation, you could tell the patient to that you're going to measure any type of deviation. So basically, the person should be standing, draped the patient with a gown, or if you do that, open the gown through the back so you could see the whole spine. Place yourself far enough back so you could see the entire back. Through the inspection, you would know first whether the spine is straight. You would actually trace an imaginary vertical line from the head to the toe to the actual sacrum. Okay, and you would note if there is any deviation. You could also note this by equally put the shoulders in position. So if you have bilateral shoulders or at the same lane of space, if they're symmetric, scapulars are symmetric. What about the iliac crest? Are they symmetric? What about the gluteal folds? Look at the gluteal folds when the patient is standing facing your back, facing the back towards you, I'm sorry. So is the gluteal folds symmetric? Most of the time the patient is normal. What about from the side? You could know the normal convex thoracic curve and the concave lumbar curve. An enhanced thoracic curve is called kyphosis. This is very common in aging population. And a pronounced lumbar curve is called lordosis. Now palpate the spinal process. Normally, they're straight and non-tender. Palpate the paravertebral muscles. They should feel firm with no tenderness or spasm. If the patient has any lateral tilting and forward bending, this could occur with herniated nucleus pulposus. Let's talk about fractures. You have the oblique, and you have basically a picture representation of the oblique. You have the comminute, which is basically a fracture of multiple pieces. And you have the spiral, which is very common in pediatric population, and compound, and this is basically open fracture. Let's talk about shoulder pain. Shoulder pain basically is associated with tendonitis or supraspinatus muscles inflammation or supraspinatus bursitis. How do you normally do the exam on the shoulder? Well, basically, you are going to inspect and compare both shoulders posteriorly and anteriorly. Check the contour of the joint to see if the patient has no redness, no atrophy, no deformity or swelling. If the person reports any shoulder pain, ask, can you please point to me where the pain is located? Palpation. Noting if the patient has any muscle spasm or swelling or heat or tenderness. Start at the level of the clavicle and move down. Go to the acromioclavicular joint, then to the scapula. Test the range of motions of the patient. Any redness, any inequality of bone landmarks, any atrophy, any dislocated shoulder, any swelling from excess of fluid that could be associated with synovitis. You could tell the patient to, with arms at the side and elbows extended, move both arms forwards and up. Rotate internally, externally. You could do forward flexion with an 180-degree angle. You could do all the movements, abduction, adduction, external rotation, internal rotation. Look for limited range of motion. Look for asymmetry. Look for pain with motion, crepitus, etc. Now let's talk about rotator cuff disease. This is an injury that includes tendinitis and partial or complete tear of the supraspinatus or infraspinatus. The symptoms are basically shoulder pain associated with weakness. Etiology normally is present in sports, is related to sport. Any strain of the rotator cuff could be traumatic or infectious process. Any activity that requires the arm to be moved over the head will produce this type of pain. For example, pitching in baseball, lifting heavy weights over the shoulder, serving the ball in a racket sport, swimming, would increase the risk for this type of disease, as well as it would increase the pain. The supraspinatus tendon is thought to be particularly susceptible because it has an undervascularized region near its insertion of the graded tuberosity. The resultant inflammatory reaction and edema further narrows the subacromial space, accelerating the symptoms. The symptoms again are pain that is worse between a 60 to 120 degree angle. So basically when the patients move the shoulder above the head, they would have pain. They have pain when they're moving and trying to turn in bed, or when they're resting on the side with the shoulder under. It could be associated with weakness. Diagnosis basically is by physical examination and MRI. You could also do a certain test, which is called Apley scratch test. Basically try to reach above overhead and behind the neck and try to scratch the opposite scapula. And the patients, of course, would have pain. There are many other tests that could be done for this. Treatment is basically NSAIDs, exercise, and basically the exercises to strengthen the shoulder. For example, you could tell the patient to lay on the left side and grasp a light dumbbell in the right hand, and with the elbow bent 90 degree, maintain this position throughout the set, and that should improve. You could also do deltoid exercises, basically range of motion movements to improve pain, besides NSAIDs, and the ultimate treatment is surgery. Again, what exacerbates the pain in rotator cuff problem, which is an important etiology for exams and practice, very common, is pain with overhead movements. Pain at night when trying to turn, pain over the subacromial bursa. Was there any injury? Have you fall outstretching hand? This may suggest also rotator cuff tear. This is very common in sports. Do you have any type of cervical radiculopathy associated with it, like paresthesias, any numbness? This is the subacromial space, okay, where the supraspinatus and infraspinatus is inserted, and the patients would have tenderness over that space with palpation. This is the empty can test that could be done as well. Patient attempts to elevate the arms against resistance while the elbows are extended. The arms are abducted and the thumbs are pointing downwards, and this hurts on the shoulder. You also have the Hawking test. The arms is forward elevated to 90 degrees, then forcibly internally rotated, and this hurts. And the Neer test is basically for impingement of the rotator cuff tendon under the coracoacromial arch. The arms is fully pronated and placed in forced flexion, and this hurts also at the level of the insertion of the supraspinatus and infraspinatus. Besides, remember the Apley scratch test is another one. How do you diagnose this type of diseases? Basically, history of trauma, history of being present in sports. Every time I elevate my arms over the head, it hurts. Every time I try to turn in bed, it hurts. But always rule out any fracture or dislocation with an X-ray. MRI is the best to confirm rotator cuff tear. Now, be aware of possible complications such as frozen shoulder, and so try to do early exercises. Now, other types of disease process that you should assess is the golfer elbow, which is the medial epicondylitis, and the tennis elbow, which is the lateral epicondylitis. And basically the test for this is to flex the elbow and pronate the hand, and this could produce pain as well. Now let's talk about finger and wrist. Basically, you have to assess the patient for any type of carpal tunnel syndrome, which is compression of the median nerve as it passes through the carpal canal. And symptoms basically include pain, paresthesias in the median nerve distribution. So it's very common and is most often occur in women aged 30 to 50, but it could occur in any type of population. Risk factors include diabetes, hypothyroidism. Remember, constantly using the fingers, such as typing or computer. Symptoms. Basically, patients have pain along the distribution of the median nerve, which is the palmar side of the thumb, the index and the middle finger, and the radial half of the ring finger. Sometimes it could involve the entire hand. Typically, the patient makes a night, the pain is at night with burning or aching, numbness, tingling is also associated. If it's chronic, patients could have tenor atrophy. Diagnosis is basically by nerve conduction study or clinical symptoms. And we have different signs that is very important to approach. And these are the Phalen test and the Tinel test. So basically, Phalen test is you ask the person to hold both hands back to back while flexing the wrist 90 degrees. Acute flexion of the wrist for 60 seconds produces no symptoms in the normal hand. If the patient has numbness or burning while doing this, it's a sign of carpal tunnel syndrome. Tinel sign, on the other hand, is direct percussion of the location of the medial nerve at the wrist, and this normally should not produce any symptom. If it's any pain, any burning, any tingling sensation while doing this, is a positive Tinel test, and we have pictures for that. This is the Phalen test, and this is the Tinel test. And this is the end of the first presentation, so we'll proceed with the second part of musculoskeletal. Thank you for your attendance.